Welcome, listeners, to the September edition of the Journal Club podcast. I'm Joe Domino, a resident of the University of Kansas, and I'll be your host for this episode. Today, we'll be discussing a topic that can be daunting to address, but is certainly something every neurosurgeon faces, and that's complications. We'll be discussing an essay-style article from Dr. Morcos entitled Neurosurgical Complications, Forgive and Remember. With us today is the author. Dr. Morcos, would you like to introduce yourself?
Sure. Thank you for having me. I'm Jacques Morcos. I'm professor and co-chairman of neurosurgery at the University of Miami, where I've been the last 26 years.
Very good. Thank you for joining. Dr. Camarata is our guest faculty. Would you like to introduce yourself?
Sure. I'm Paul Camarata, president and chair at the University of Kansas Department of Neurosurgery, and a dear friend and colleague and co-resident of Professor Morcos. And I'm related to you too, Joe.
Yes. My mentor, certainly. Thank you for joining us. And Dr. Huang, would you like to introduce yourself?
Yeah, I'm Kimberly Huang, and I am an assistant professor of neurosurgery at the Winship Cancer Institute over here at Emory University.
Thank you very much for joining us. And again, I'm Joe Domino, PGY7 at the University of Kansas, and I'll be your host for this episode. So Dr. Morcos, would you like to start us off with a summary of the paper and perhaps the nidus behind writing this piece?
Yes, thanks, Joe. Really, the idea actually was not mine. The idea was my good friend Peter Vashkozy, who's a chair of neurosurgery in Berlin at Charité Hospital. He wrote a book which is now published, and he was asking his friends to write very short essays about different topics for his book. His book was really a reflective book. It wasn't a scientific book about neurosurgery. And he asked me to talk about complications, how I deal with them in cerebrovascular and skull base. So I wrote a little something, sent it to him, and then got me thinking. It's published in German, by the way, that book, not in English. Then I thought, maybe what I've written would be of interest to obviously our English-speaking audience here, particularly in the US. So I expanded on it and presented it to neurosurgery, and it was accepted, and that's the story behind it. I can say, if I'm happy to summarize briefly what's in it, or maybe we can talk about it later part of the questions, whatever you'd like.
Yeah, I think we can jump into some questions. I think we'll get to a lot of that throughout. So I'll open the floor to Dr. Camarata.
Well, Jacques, in skull base and cerebrovascular surgery, and the complications are undoubtedly, or can be, horrific or devastating, as you mentioned in the article. How do you deal with that, on a personal level? Do you try and remain? You've addressed some of this in the article. Do you try and remain aloof? I know you don't bring it home, or do you? Undoubtedly, you carry some of this with you. The Riche quote on that we all carry the cemetery around with us. Tell us a little about how you deal with that.
Yeah, absolutely, Paul. And you and I, as we all know, we know you and I, we have common lineage. We owe a lot of perhaps our philosophy with dealing with complications from our mentor, Roberto Heros, who there is nobody more honest and forthcoming with their approach to dealing and recognizing complications as he is, as I'm sure you'll agree with me. And as you know, he has been my partner many years. So I am pretty sure a lot of my own philosophy about dealing with complications has rubbed from his teachings. Mm-hmm. And the bottom line is honesty to oneself. And yes, they can be daunting and devastating, and losing a patient, we all know, absolutely will hurt you. You may put a brave face, but it absolutely hurts you. The only way I felt and learned over the years to deal with it is to analyze it, call it what it is. If there is a certain mistake that happened, just recognize it, and don't repeat it again. And that's a brief answer to your question.
And then to try and do what you can, if it is a preventable complication, to keep it from happening again. And we learned that from Roberto. I tell my residents I was involved. I was in the case that he presented about the subclinoid aneurysm that people still talk about, and how he, had the the courage to write about that in that article in the Red Journal. So it's you're right. It comes from incredible mentorship, and that's how we learn to deal with these things.
By the way, Paul, he told me that he cannot count the number of times people would stop him in different countries, different conferences. Dr. Heros, thank you for publishing this case. You prevented me from causing complication. Those are very meaningful. The honesty in stating the tragedies that we've lived. I mean, that's what legacy is about, is so that people don't repeat your own mistakes.
One other quick question on that note. I think you were there when Charlie Drake came and spoke to us at Minnesota as visiting professor. Yeah. And he would put up his slides, Mr. Johnson, Mrs. Smith, Mrs. Collison. He remembered the names of every patient, showing these complications. Does a similar thing like that happen to you?
I'm not as good as Drake was with that, but Roberto certainly would remember it. Charlie Drake, if you recall, would remember what they did for a living as well. And no, I cannot say that I remember all those details on my patients. I do on the ones where things have not gone well, of course, because then you get so deeply invested in their well-being, and you want things to go well from here going forward.
Great, thank you. Dr. Morcos, a quick question for you. Do you think that managing these complications becomes easier through your career, or perhaps the challenges change over time? Just thinking about as a chief resident, looking at cases where you feel more responsible and taking more responsibility for your patient, moving into junior faculty and then more senior faculty now looking back.
Yeah, I get this question. I've gotten this question many times, Joe, particularly from my own residents and from younger faculty. So looking back, yes, I would summarize by saying it gets easier, not because the complications are less intense, but because your ability to adapt as a more experienced surgeon to tragedy. Just growing up as a human being, forget being a surgeon, just us growing up as men and women, and you just learn from life. So yes, it is certainly, I am much better at handling a complication now than I would have been 15 years ago. The complications don't get easier per se. As a matter of fact, the more experienced you become, the bigger cases you will handle, and therefore the potential for bigger tragedies are there, and they occur. The way I rationalize it, and as they say, I can get back on the horse the next day onto the next case, is to say, have I done my best? If I have not done my best, then I'd better pay for it. If I have done my best, no matter, to be honest, how tragic the complication is, it's a little more palatable, particularly if I've done the proper decision-making, gone through this, as I say in the article, you rerun the whole movie in your head, and you say, well, where did I screw up? How bad did I screw up? So if I can rationalize, analyze all this, and run my own, court proceedings in my own mind, and say, this was a tough case, it's more palatable, and you can get back on the horse the next day.
You mentioned in your article the importance of preoperative counseling in the office or, before surgery as a way to sort of deal with complications that arise in the postoperative period, and how important that is. And I've certainly felt that in my practice. What are some practical tips or tricks you can give for trainees or young attendings like myself to sort of really make the most of your preoperative counseling and to sort of set those expectations for patients so that when a complication happens, it's potentially not as stressful?
Yes. Yeah, it's a great question, Kimberly. My first piece of advice, and all of us here are in academic institution, we train residents, we train fellows. It is the duty of the attending to discuss operative consent with the patient. It is completely unfair to ask a resident to discuss the subtleties of an operative consent in a case. And and I'm not talking medico-legally, I'm talking from a human perspective. Yes, of course, it's better medico-legally and that you're going to document that you said, but I'm not talking about that. We owe it to the patient to answer, not in a generic way, what this craniotomy for this cavernous sinus meningioma is. No, you need to specify, in your case, I think the third nerve is here and the sixth nerve is here. And I think in your case, I'm more worried about this and I'm worried about that. How can we expect a trainee to know that? They don't. Let them listen to you, listen how you tailor your operative consent discussion with each case. And of course, that's how they'll build their own confidence in doing it. And I'm all for complete transparency with the patients. When I sit in the office, a good friend of mine, God bless his soul, Bernard Georges died now. Bernard would sit next to his patient when he would discuss consent, not across the desk from the patient. You've got to be trusted. And if they feel you're not, you're treating them like human beings, that's what you want to do. So I often come, I bring my chair, I sit next to them. And yes, I put a hand on the shoulder and all those things, but that's not an act. That's how you feel about it. And that's what I want to portray to my patient.
Yeah, I learned from Roberto, as I'm sure you did, the moments before they wheel back to the operating room are not the times to go through all of these, horrendous complications that can happen. He would grab their hand and say, everything's going to go perfect. It's going to be great. Don't worry. We've talked about everything in the office, but everything's going to go well, just to give them that confidence before going in.
Oh, it's true. You can't, the fact that they are in the pre-op area, it means that they've already analyzed the pros and cons and made that decision. How could they have made it without you having thoroughly talked about it? And the other thing, Paul, I'm not sure how you do it, whether you use a lot of statistics. I use to some degree. You need some objective science a little bit, but you have to color it. You have to put it in context. And I may speak differently to two different patients about the same exact operation. We've got to be good psychologists, analyzing, what will not, you're not trying to fool the patient. You're trying to really communicate essential information for the decision-making. Two different patients with two different psychologists deserve different presentations, don't you think?
Oh, yes. Yeah. No, along what you said about Dr. Drake and Shelley Shoes, another person that used to do this, what does the patient do for a living? I ask my residents that all the time. I think Joe knows by this time that he better know, because you're going to maybe talk differently about a surgery in, a low-grade glioma and eloquent cortex to an attorney than you are to a truck driver or a carpenter or something like that. So yeah, I think those are very important things. It was a part of your article, the fundamental part of dealing with complications, the art of communication, and you don't clam up. How many lawsuits have we seen or we've been asked to consult on, where as soon as a really bad complication happens, the surgeon ducks away, disappears, stops seeing the patient. No, that is the time when you have to over communicate.
Yes, yeah, very true, absolutely.
Dr. Morcos, oftentimes, as we finish up, attending may go talk to a family. They may leave their trainee finishing up getting the patient off the table back to the in recovery and all of that. So they may not be a part of those conversations all the time. And even when things go well, I know that, sometimes I'll make an effort to, go along with some of our, some of my mentors just to see those conversations or, be a fly on the wall. Do you involve your trainees in some of these discussions, or have you ever, or been privy to, seeing, one of your mentors or Dr. Harris, talk to a patient and their family about when something does go wrong?
Oh, absolutely. Actually, I mean, it's part of the rounds. It is essential. It's essential part of the training. When you sit down and you try to analyze it, because the patients get lost in these situations. They see the junior resident rounding at 6 a.m. and then the chief coming later and the nurse practitioner, and they're bombarded often with so-called contradictory information. So you, the captain of the ship, need to bring everybody, all those faces that they see and they perhaps misunderstand or it's not communicated well. When they see them with you, you're giving a consistent message. Everybody's standing there. So that's one advantage. Second advantage is the residents need to learn how to talk to patients, correct? And I mean, I don't know how else you can't read a book about it. We need to come and see how Paul Camarata, how I do, how we over the years, what worked for us, what doesn't work, and those four. Yeah, absolutely.
I envy, the part of your article where you said you don't bring anything home, because I tend to bring things home. I try to keep it away from my family, but my wife says she can always tell when I've had a really tough case because my sleep is affected. She said you're sweating a lot during sleep, and I've had dreams on, AVM's gone bad where I'm just seeing blood and more blood. So she can tell, even though I try and keep it away.
You mean before the surgery or after the surgery?
Right, yes. Very good. Touche.
Yeah, Paul, I have been very good about, really not, I mean, my wife, Fiona, I do not bring anything home, really, truly. It's for the reasons I mentioned in the article. Number one, you need to have your own space when you come home. You have your family, and then to keep mulling over it. No, the mulling has happened at work, and now, otherwise we might as well be 100% neurosurgeons with no other portions of our life. That's not the equanimity that Joe Maroon talked about in that article back in 1985, or the proper balance if in one's life. That doesn't work. That doesn't work for me, at least.
Sometimes families may or patients may feel a little bit shut off after a complication, and they may certainly feel withdrawn, or you may try to talk to them and they're not really wanting to hear, or they may need that time. How do you manage in situations where it's evident that maybe they need a little bit of space to kind of process, or when do you go back? How often do you talk to a patient and their family in that kind of setting?
You're really asking, Joe, really very good questions that don't have an algorithm. Right. I know. I'd love to tell you I have a nice algorithmic way to deal with it. And the good thing about trying to be a good psychologist is you get that inner sense of what works with one family, what doesn't. Some families are desperate for every bit of information you can give them. Some are in a little bit of a denial. So you give them the information a little bit at a time. I would say the common thread of how to do it best is they need to trust you. I mean, you've got to look in their eyes as you're talking to them. Are they looking at you in an angry way? Are they looking at you as the person who hurt my mom or dad or brother or sister? And you need to cross over. You need to leave this, we're in academia, we get blamed of living in an ivory tower and so forth. No, you need to break those barriers, whatever it takes. If it takes an embrace, if it takes a hug, if it takes a sentence of, trust me, I'm just telling you whatever it takes, you've got to win them to your side. And now sometimes you can't, and there is nothing you can do. And but they need to see that you are hurting like they are, and it cannot be an act. They will absolutely recognize that you are fake. It cannot be an act. If they see your sincerity, that's half of the battle won. The rest, then they will trust you. If you're sincere, you show empathy, you gain their trust. Again, it sounds like you're doing it in order to get there, but that's not why you're doing it. You're doing it because that's the right thing to do.
Right. Yeah, I appreciate that. Yeah, obviously, this doesn't come with an algorithm, and then there is no, there's lots of right ways to do it, and that's why I think your article is so important and helpful for us.
What about your own ego or your confidence? When something really bad happens like that, how do you deal with that?
Yeah, you question it, Paul. You question it. You say, well, I mean, it depends what actually happened. Oh man, I was too aggressive. Why did I remove that last 5% of tumor? Should have stopped. And obviously, the way you and I practice today, Paul, after many years of practice, is colored by those earlier mistakes we've made when we took a little bit more tumor, when we maybe didn't put a temporary clip on the on the parent vessel before you clip an aneurysm, and it tore at the neck. And I mean, we are the product of our former mistakes, and which is what obviously experience is. The ego, I mean, I don't know that I can say, well, I mean, of course you need to stay humble, but you don't want to destroy your confidence. It's okay it's okay to temper your ego. You should, I mean, I don't know what we really mean by ego when we say it. Confidence isn't ego. Confidence is good. But certainly arrogance is not. Confidence is good. Yeah.
Yeah, and to remember your complications and to study them. We all do that in our M&M, in a focused manner. And I tell residents, I go into cases now, and I'll be clipping an aneurysm or doing a bit of dissection somewhere, and I can literally remember the room, the evening that we discussed the complication in, being in, that Mayo, 5th floor Mayo room at the University of Minnesota, and the evening that we discussed the complication where this tumor was attempted to be removed from the sagittal sinus, or where the clip went on and the neck tore. And I remember those conferences just as I'm preparing for the case,
I also get similar experiences. I get, let's say I'm doing a step in some surgery that I've done hundreds of times before, and in my head runs a saccade of movies, like little snippets of previous times where it wasn't done perfectly, that I haven't done it perfectly. And it's fast. Yeah, I mean, I guess that's what training is all about, and developing experience.
Oh, great. This was such a great discussion, and really want to thank everyone for joining. As we wrap up, I'd like to sincerely thank our panelists, Dr. Morcos, Dr. Camarata, Dr. Wang, for joining us and really making for a fascinating conversation. Thank you to our listeners for tuning into this episode of the Journal Club podcast. And I'd like to remind our listeners that today's podcast activity is available for 1.5 CME credits through the CNS online catalog and is complimentary to CNS members. And I'd just like to conclude by saying thank you, and please join us again next month for the October edition of the Journal Club podcast.